Uh-oh.
All right. Is this, we'll call this episode 2, I guess,
Okay.
Since we'll be the second one on YouTube. My name is Dr. Adam Schwert of Run Mental. Accompanying me here is Dr. Dylan Collier of Dylan Collier, New Medical Notes Podcast. Anything else coming up? Anything else?
That's it.
That's it?
Follow me at Dylan Collier, and then New Medical Notes Podcast for traveling physical therapists and other allied health professionals or nurses.
Nice.
Boom.
You've been practicing. Then to my right here is a student physical therapist, Emily Mack. All right. So, Dylan, do you want me to go through this article, or do you want to do the little intro and the name and everything?
Sure. I'll kind of go through how I found it. So today we're looking over an article called "Evaluation of Evidence of Statistical Support and Corroboration of Subgroup Claims in Randomized Clinical Trials." And it is a article by Ioannidis, and Ioannidis is a researcher that kind of does research on research. So not a meta-analysis, although this is kind of a meta-analysis, but it's more of a thinking of research.
Anything, I'd say it's more systematic review.
I'd agree with that. Yeah.
Maybe.
Yeah.
But not officially by definition systematic reviews.
But Ioannidis, his goal is to kind of make research better overall. So he looks at problems that we have, and then he comes out with these types of articles and makes statements of how we can fix it, and basically how to be better practitioners of research literature and looking at evidence-based medicine. So I initially heard this on the PT Inquest, their podcast. I thought it would be really good to go over as a group of clinicians, but also for other people who read research on a semi-regular basis or regular basis.
Yeah, definitely. Yeah, so kind of going into the, why would somebody look into this? A lot of studies, they get a group of people together to try an intervention. And then, maybe they find something, maybe they don't. And then they go back and try to look at other things, other, quote unquote subgroups, where, they try to find something significant amongst that specific group of patients, which is maybe not the best way to go about it. So this didn't look at much physical therapy research in particular. So I wanted to give just a little example of what this might look like, or what that would mean in the physical therapy realm. So if you had a group of patients all with rotator cuff tears, and you applied some exercise, we'll call it exercise X, because it's the X factor, that, these researchers think are going to be, it's going to be the exercise that gets everybody better. So they do the research, they find out, they didn't really find much, which in itself is something. So don't forget that. Don't go looking for something if you are a researcher just because you didn't find anything. Nothing is always something. That's what I always say. So they found nothing, and then they go back and try to look at everybody who also had maybe like a labral pathology with it. And it just so happened that those people tended to have less pain or improved function or whatever the outcome was. And so they make the claim that, exercise X was like the thing for people with rotator cuff and labral pathology, which we'll dive into why that maybe not be the best way to go about it here momentarily. Anything else to add or say there?
For another example, for physical therapy wise, we see, or I've seen studies looking, especially low back pain. So low back pain is a very hot topic right now in the medical field, because costs keep going up and our ability to treat it is staying the same. So costs are going up and more people are getting low back pain, and we're having this issue within the medical field of not being able to treat this group of people. So individuals get curious about that. They start doing research, and they think, oh, well, maybe if we can classify the different types of low back pain, then we can treat them better. So we'll call it, if you hurt more when you flex forward, flexion-based. If you hurt more when you extend, it's extension-based. Or there's been several other different attempts at low back pain. And a lot of physical therapy research that's done subgrouping, from what I've seen, has been in that. And so they try and come up with these different ways of looking at low back pain with these different subgroups, and then they come out with their conclusion at the end. But I think that's how this study really fits in well with physical therapy as well. And I think that might have been one of the examples that they looked at. But
in the study or the
maybe PT and Quest?
I think that's what they did. Because when I first read this, even in the title, I was like, wait, I thought this was all about low back pain. Because that's what it is advertised as from here. My bad. And then I listened to their episode and realized I think it was all them, because that's what they. So this isn't so much as we look at an intervention or we look at something and now we can better our practice from it directly. It's more how can we critically evaluate and read through the research that is about physical therapy. So in that way, there is still definitely value to this.
That's what I have for the intro.
Okay, cool. I drew up. I should have grabbed this. So overall, we see this? Probably not. Maybe not. All right, we'll leave it here and we'll talk through it. So they found there were 64 randomized controlled trials that had some sort of subgroup claim. Only 46 of those had significance. So that means 71 of those, 117 had no significance whatsoever. So right there, you're kind of like, well, what's going on with that then? Of those 46, 16 ensured balance with randomization within that subgroup. So that's important. We understand the importance of randomizing people so that the intervention isn't being selected to those that just may respond well and therefore show significance later on. But when you go back to subgroup, you have to make sure that that subgroup is equally randomized in that same manner. So you can't have, I don't even know. You guys can explain that?
I'll kind of backtrack just a little bit.
Yeah.
So when they were looking at the studies that they were going to include, they had a couple different groups that they looked at, and then they scoured the internet for people who had subgrouped and then found a significance and talked about it within their abstract. So they went in their abstract, they included it. Of 117, when they actually went into the article, they did not find a statistical significance. So they were saying it was significant or saying that there was a trend when actually, when you looked at it with a 0.05p, there was no significance. Then they went and looked at, okay, so did they randomize it? Were the groups equal to each other? Were the groups, there's criteria in a way that you can stratify to where you randomize the groups that you're looking at, and very few did that. Only 13. Is that the number that we have?
Mm-hmm.
Only 13.
No, 16.
Only 16.
Yeah.
13, only 13 of these 46 that showed some sort of significance actually pre-specified that they were going to go back and look at that specific subgroup.
Incredibly.
Yeah. And so that's an issue, because if you decide that you're doing a study, kind of with your example, you do rotator cuff tears, labral pathology, and you don't find anything, and you're like, oh, but I spent all this time. And then you're going to start going back and double dipping and looking at all this data and say that there's something here. There's got to be something here. You start doing more tests and doing more math on it, and then lo and behold, something pops up.
Mm-hmm.
Well, if you do, the more tests that you do, the larger sample that you need to in order to power it appropriately.
Mm-hmm.
And if you keep doing that, and they call that, I think it's like fishing for data.
Yeah.
And only 13 out of those 46 pre-specified it, which makes it more accurate or more believable that they would have a correctly powered study.
Correct.
And I thought it was crazy. So I don't know if it's just because we're either still in school or still relatively fresh, so we still kind of understand research and how you should go about doing it. But only one of these 46 actually adjusted for going back and looking at it. Because each time you go back, you have to make that p-value a little bit smaller, so that, because it does make it easier to find stuff. So when you make that p-value smaller, it's less likely that it's going to be significant when it actually isn't.
Right.
Like
So
false positive.
Right, false positive. And so a p of 0.05, if you think about that, it's limiting the risk of a false positive, but every like 1 out of 20 studies is going to have a false positive. And so that's why you tighten it with every time you go back, because you want that true positive or that true.
Well, and something when they ran like their own analysis on these, I noticed that they did a two-tailed 0.05, which, correct me if I'm wrong, but wouldn't that even further, like, because that means it'd be like 0.25 on this end and 0.25 on this end of that normal curve. So even they were being even much more stringent in what they accepted as significant.
I imagine that wasn't a physical therapy study.
And so then your big thing here, that once, even if we make a let's get the cat out of here. So once we make a subgroup claim, we need to then go back with a follow-up study and confirm that, because it is so easy for it to come across that false positive. Only 5 of these had attempts at a follow-up study to find that. And none of those attempts ended up showing anything significant.
And none of those attempts were purely followed the same type of research or the same attempt as what they were basing off of, correct?
Yeah. Okay. So I definitely want to applaud all these authors for diving into this, because this is big time. They tracked down a ton of studies and then dove into each one of those studies and reanalyzed everything. So 2 thumbs up for them. Now they did have a little help, sounds like, from some previous research with a satire group and a disco group. Satire meaning,
Go ahead and say it.
Is it? Yeah, if you got it up.
Satire, the acronym for subgroup analysis of trials is rarely easy, which, I don't know, I kind of laughed at that.
Yeah, I did too. That's good.
Just nerds trying to be funny, I suppose. But and then discontinuation of randomized trials was disco.
Yeah.
And those look to be, what I found is, at least for satire, an original article that went into subgrouping and then came out with their own procedure on how to do that subgrouping. I think they based the questions off of that. But I do believe that it looked like there was a span of like studies, and I guess they went back and they looked at those groups that was either included in the study or within the organization.
Yeah, and then DISCO is a discontinuation of controlled trials. And that's just, for whatever reason, maybe they didn't get enough of a population that they wanted. Maybe I don't even know. For some reason, they had to discontinue the study. And then, but I guess they still report the data something that what they do have.
It might be a group as well as for like you were saying before, if you go through and your hypothesis is null, that's still something, but it's not very publishable. So a lot of journals aren't going to publish this like, well, we did this and then it turned out to be a flop. So I think this might be a group where you were able to submit it. You won't get paid or get reimbursed or anything like that, but it's still out there, and then they took those articles and looked at it.
Gotcha. Okay. So they mentioned a few, some of the stuff we already talked about, but I highlighted a few things in the intro about the problem with previous research and subgrouping. One being that the presence of a statistical effect in one subgroup, but not the other, does not constitute evidence of a subgroup effect. Second being that trials often perform numerous subgroup analyses that are not pre-specified or adjusted for multiple testing, which increases the probability of a false positive finding. And then third, most trials fail to randomize participants within those subgroups. And that's kind of the big thing. Like, you can't, because of this, you can't take away, you should not then apply it to, your clinical practice. You should maybe dive a little bit deeper, find some of those studies some follow-up studies where you can then, make a definitive conclusion on whether or not it should be included in your clinical practice or not.
Yeah, that was basically their 3 questions that they included throughout the entire study. So that was nice. They basically looked at the problems that they saw.
This is this is their 4 questions here. They looked at, so the 4 questions, so when they pulled up an article, they went through 4 questions, make sure, hit those check marks. They were, how often are subgroup claims reported in the abstracts or RCTs? How often do these subgroup claims have formal statistical support? How often are the abstract subgroup claims with formal statistical support based on a subgroup stratification factor at randomization, pre-planned, and based on analysis adjusted for multiple comparisons? And then 4, how often are the abstract subgroup claims with statistical support corroborated by subsequent RCTs and meta-analysis? And you can watch the re-recording on YouTube later or on live in the next 24 hours for those 4 questions again. That's a mouthful.
That was a lot.
Yeah, so if you wanted to, so you found an article you like, and they found this subgroup claim, and you wanted to kind of figure out how can I find a follow-up study? A great way to do that is, I believe on PubMed you can go to, or on a lot of journal sites, you can see what articles cited that article.
Even on Google Scholar.
Or even on Google Scholar, okay, cool. Or there's also, what they used was the search engine Scopus, where you can search a title of a study and obtain a list of all the articles citing that study of interest. So that was pretty cool. I didn't know about this Scopus.
Which is really cool, especially if you find like an older article and you're looking at that, but maybe it's past the 10 years that you want to use in your current research, or you just want something more up to date. You can use that older article to lead into the newer articles and see what their questions are.
Yeah, definitely. Okay. So as with anything, there are definitely limitations. Even when you're trying to critically analyze, you have certain limitations. One is that all the articles they pulled from were between 2002 and 2012, and for that latter half, it may have not been enough of a window for follow-up research to come out, which maybe then changes their conclusions about whether subgroup claims are valid or not. Our research, we're not full-time researchers, but our research during school takes almost 2 years, was it?
Yeah.
That's a long time. So if something came out in this year, 2017, you're going to be sitting around for a while before you can, find something definitive, if somebody's even working on that. Another issue that they potentially had was with their follow-up search engine of Scopus, using the search terms that they used, their search strategies. They may not have found all the articles that were claiming to be like a follow-up study for a previous subgroup claim. So those are big to keep in mind. But overall, they looked at a lot of stuff, looked at a lot of articles. Not a lot of significance with the follow-ups. Not a lot of great, statistical significance to show what was claimed. So, anything to add?
This was a difficult one to read. It was very nitty-gritty. Definitely not like the physical therapy related articles that we're used to reading.
Yeah.
But outside of that, yeah, I was looking at the percentages, and I think it was only of the randomized control trials that were saying, hey, we found a significance in their abstract, only 40% actually had a statistical significance.
Yeah.
Which that's nuts. But the reason I wanted to bring this up is that just because there's a study out there, you can't just necessarily go on it. And especially if it's subgrouping, I would just probably, right now, if I'm reading the subgrouping, I'm probably just going to ignore it. Just because we're still in the process of making studies better. When research started, it was pretty simple at the big things that we wanted to look at. But as we get more focused and more specialized and niche within each profession, it's harder and harder. And then with the biases of like who's supporting the study financially and kind of the politics that go into it, like we said, a lot of journals aren't accepting ones with like null hypotheses, even though that might be something the profession needs in order to make something die out that's not working. So I see, playing devil's advocate, some people out there who really bash on research and kind of just go with their clinical experience. But the whole thing behind research is to make sure that you can't just go off your personal experiences. If you have a patient that walks in, you get them better in 2 weeks with whatever treatment, but then 2 weeks later that are chiropractic or they're back at their medical doctor, or it gets worse and they just deal with it. You don't know. And so studies and research are a really good way in order to get the correct amount of volume of patient population to make sure that we're actually making, a change and that it's staying changed 2 years out. Well, most physical therapy journals are like 13 weeks, but 2 years would be awesome. I see some people.
And that's another reason why it takes so long for follow-ups, because, we can't just have these 6-8 week, interventions. We need, and then, conclude the study. We need to then have follow-up 6 months later, a year later. Ideally, 2 years later would be awesome. But yeah, go ahead.
So I see some clinicians kind of using this as ammo for the ones that aren't as evidence-based as we would like to have the profession. But it's still a learning process, and you're just asking questions over questions, the yes and no's, and then eventually you get to the final question that you want to ask. But it's a slow and endearing process.
Yeah.
So maybe now's a good time to plug in what actually is evidence-based practice. Does the student want to throw the student on the hot seat?
Man.
And I think there's 3 components.
There's 3 components.
Okay.
Obviously, one is what's supported by research. There is a component of clinical experience to that, because you don't want to just completely disregard what someone that's been working for 20 years says works, but to be honest, I can't remember the third. This is really bad.
It's what the patient wants or needs.
Oh, yeah.
Is it something with the patient?
Patient-centered type of
care. So if you get someone coming in like, hey, ultrasound made me better,
you
might have to grit your teeth for a little bit and do an ultrasound for a treatment or 2 and then get them off there.
Because, placebo, you can't argue the impact of placebo sometimes. If they really believe that it's going to help them be better, then it might just, by the simple fact of they feel like it's helping. So.
Can we go into something? I'm ready. So,
let's do it.
Research-based, you want to
now keep in mind, we got 10 minutes before our...
Okay, all right. So, research-based, when you talk about that, it's not looking at one study saying,
correct,
this is what the research says. No, you have to look at the entire body of knowledge.
Yes.
So like I said before, the P of 0.05 means that 1 out of every 20 is going to have a false positive. And we've discussed that subgrouping in other studies might be conducted poorly, and they're getting passed by these journals because they have the significance and they have all the different pressures of trying to be more readable and get more funding to keep the journal going. So it seems like every clinician out there says that they're evidence-based, but then they haven't read a study in 2 years. I don't know. That's just something that I kind of struggled with, and I haven't dealt with that for a while. That was more when I was a student. But just like just because there's one study that shows that doesn't mean that's what's actually going on. You have to look at the entire body, and then if there's kind of the weak studies of we found an effect. Well, I mean, some things just have an effect no matter what you do. You can hand them a bologna sandwich and
maybe not bologna, but
well, and something they did in this study that I think is really important, and they mentioned most studies don't always do, is looking at that interaction effect. Because from what I can remember from research class, which was a little bit ago, the interaction effect is like, okay, you found a significance, but now you look at the interaction of the variables to see, is it truly because of that interaction of these variables, or is it just something that's kind of just happen to be significant. Right. And I think I feel like that shouldn't be that hard of an analysis to run if you're already running all of these other analyses, but I could be wrong. We haven't gotten to we're almost to the stats part of our research.
What's nice about this one is that this is a profession-wide, not just physical therapy, but research-wide issue that's going on with subgrouping.
Yes.
They had, let me see if I can find the tables. They had ones with looking at like medications versus placebo. There was one supportive group therapy versus control, standard care versus standard care with intravenous cooling, and then I thought there was a nutritional one, but I think it just had a natriuretic peptide in there, and that was something to deal with neurological symptoms, but not just physical therapy. So this is something to keep in mind for all professions. But that's my big takeaway. So if I'm reading something and it says subgrouping on it, I'm at least going to use these 4 questions to filter it, and then most likely not pay too much attention to the takeaway.
Yeah. I wanted to add on to the evidence-based practice for the clinicians. I love all the blog posts and the social media stuff, and the CEUs that are have all the references. But until those are great resources to kind of get you moving in the right direction. But until you go back and at least look at some of that research, you don't know 100% sure if they're inferring the correct stuff from that research. Correct. They could have pulled out one line from a 7-8 page article that really doesn't portray what that article is actually saying. So you just need to listen to that. There's a lot of great stuff out there, but just make sure that you're understanding what's actually being said.
Good.
All right. So good article on all this is, again, evaluation of evidence of statistical support and corroboration of subgroup claims and randomized clinical trials. Came out in 2017 in the JAMA Internal Medicine Journal, I guess. Lead author was Wallach. Check it out, read through it. It's pretty good.
If you search Ioannidis, spelled Ioannidis, he has a lot of, they are difficult reads, but he does a lot of these types of studies where they look at research itself. And it lets you be a little more open and a little more knowledgeable of what kind of biases are going into the research coming out, so that you are just better prepared and better armed with your own information on what type of articles to take into consideration and which types to kind of just keep in mind, but maybe push off to the side.
Gotcha. Good. So this is Journal Club of Justice. We meet once a month to discuss research typically about the physical therapy profession. Thank you. If you guys have any comments, questions, suggestions for us, particular stuff you'd like our opinions on, articles that you'd like us to talk about, please send them our way. You can message me at runmental@gmail.com is my email, or on Instagram. You got Dylan Collier at Dylan Collier. Do you have a New Medical Nomads email or anything? Or? Any other way to contact you?
Just find me on Facebook, New Medical Nomads Podcast, or just hit me up on Instagram. Just message me there at Bill and Calvin.
All right. So thanks for tuning in. We'll see you next month.
See you guys.